Hi guys, so let's begin. We'll be looking at the most important topics for obstetrics. So how I have structured this session for today is first we'll be spending 5 to 10 minutes on the anatomy and physiology of the female reproductive system. This is very important for today's exam as well as tomorrow's exam. So 5 to 10 minutes for that, it's very much worth it. And next I'll be coming up with a timeline. Okay, this timeline will give you like an orientation towards the subject, like how to approach the subject and how to approach the patient per se. With this, you can easily remember the content for your exams as well as for your practice as a doctor. So that's the approach I'm going to take. Then important questions, 4 to 5 points, whatever I remember for each of them, I'll be sharing with you guys. So I plan the session to be about 45 minutes to 1 hour max. So I hope you guys find it really useful. So the basic anatomy, you have your uterus, and then you have your cervix, and then you have your vagina. Okay, and then you have your fimbria over here. This is your ovaries. Okay, that's the reason why I'm drawing your uterus like this. Usually in textbooks, it's going to be like this. This is the diagram will be used to drawing usually, but in nulliparous woman who's not been pregnant yet, the ovaries are posterior and behind the uterus. To denote that is the reason why I've drawn it like this. In a multiparous woman, it changes position like this, and both the diagrams are right, but just know why it's drawn that way. So you have your fundus of the uterus, body of the uterus, your cervix, your endocervix, your ectocervix, your posterior vaginal wall, your anterior vaginal wall. This is your fallopian tube, and you have your ovaries over here. So those are the main structures which you need to know. Other than that, you need to know the lateral view. So you have your bladder over here, and then you have your uterus over here, and you have your colon over here. Okay, and then you just remember that the uterus is sandwiched between your urinary bladder and your colon, and there are some special fascia like your urogenital fascia which separates your uterus from the urinary bladder. So when the woman becomes pregnant and starts growing, it actually turns like this and enters into the abdomen, and it doesn't do any problem to the bladder because of this urogenital diaphragm. So those are few important anatomical points which you need to know. Other than that, the basic physiology per se, you have your hypothalamus, your anterior and posterior pituitary, and then you have your adrenals over here, and then you have your ovaries, your uterus, cervix, and vagina. Okay, these are very rough diagrams to give you an idea and not waste time. So your hypothalamus will secrete all your GnRH, and your anterior pituitary will secrete your LH and FSH. All of these occur in a mature reproductively active women. Okay, but if you look at how these systems start to take place, you have your adrenals secreting DHEA, dihydroepiandrosterone. So this is the precursor for all sex hormones, including your testosterone, estrogen, progesterone. All of this is going to be the basic thing. So this will go and activate this GnRH, and then your LH and FSH are secreted, and then from your maturing follicle, you have your estrogen being secreted. Then once the that follicle is ovulation takes place, and that follicle goes and reaches into the uterus for waiting for fertilization, and you have your corpus luteum over here that will secrete progesterone. So you have a feedback inhibition where this uh, when there is excessive LH surge, there will be decreased FSH, and there are certain regulatory mechanisms to ensure that when one hormone increases, the action of other hormones decreases. So those are all the basic points related to the anatomy and physiology which I need to cover before getting into the topic proper. So let's start with obstetrics. So obstetrics is going to be related to a pregnant woman, right? So along with this pregnancy period, you add your pre-pregnancy and post-pregnancy. All right. So we'll draw a timeline like this. So this is a pre-pregnancy period, and this is a pre-pregnancy, post-pregnancy. All right. And this is your gestational period or pregnancy period. It's very important for you to have an idea of when all the different conditions will occur, and how do you manage, and what are the various investigation options you have in certain periods of time. So pre-pregnancy, what are the things you need to watch for? First of all, you need to give her education about your coitus, and then her gender health, her nutrition, all of those are going to be talked to, and about her family, like when should she have a baby, is she ready emotionally, like financially, her husband's understands all the things which are going to come with bearing a baby. All of those are going to come in your education part. Then is going to be your screening. You screen for like hypertension, diabetes mellitus, any seizures, or any infections, hyperthyroid. So these are all very important things to ensure that there is no pregnancy or disease during the gestational period, and to ensure the welfare of both the mother and the child. Pregnancy is not a disease, so you should not look at it like something is wrong with the woman. It's a very normal process which puts extra stress on the woman's body, and we need to help her like understand that it's normal, and we need to optimize her health to ensure the well-being of the fetus and the child. So that is the goal of our care. So these are your pre-pregnancy important things. Your education and your screening are your most important things. Other than that, you can give something like supplementations. So usually your folic acid supplementation can begin with adolescent period. So those are all the important things when it comes to your pre-pregnancy or prenatal care. And then moving on to post-pregnancy. So these two are really small bits, so I just wanted to deal with these first. So post-pregnancy is your puerperium. So post-pregnancy, again, you need to educate her, but this time is going to be about the danger signs for the baby. In case the baby becomes like yellowish in color, or the baby has diarrhea, or the baby is not feeding, all of those things you need to educate her, and then you need to advise her about contraception. So when it comes to contraception, you cannot suggest a contraception to her. You need to tell her about all the contraceptions which are available, contraceptive devices which are available, the benefits and demerits of all of those, and it's up to her to decide what she wants to do. So that is a cafeteria approach. And then so those two are the most important things you need to educate her about. And then again, screening for infection. So this time there's going to be like certain obstetric reasons for infections to occur. The most important one being retained placenta. Okay, so usually after the baby is delivered, within half an hour the placenta will be delivered, and you do something known as Andrew Brand procedure or active management of third stage of labor. So using that, you remove the placenta. So in case the placenta doesn't come out, you have something called retained placenta. So that is going to be like a moist location for bacteria to grow. Already in the female genital system, there are bacteria present in the outside part. So when they go inside and start proliferating, this is like a easy gateway through which they can go and attack the body. So that is the two most important things related to puprium. And then you can do follow-up, like in cases of diseases like hypertension or diabetes. You can follow up the patient to see what state their conditions are. So these are the most important things you need to know when it comes to your pre-pregnancy uh, things and post-pregnancy. So I'll start off with your pregnancy. So you split it into your first trimester, your second trimester, and your third trimester, all right? This is one way to split it, and covering a little bit of practical aspects over here. The minimum number of visits is going to be 4 visits, one in each trimester and 2 in third trimester. Your ideal is going to be uh, once a month till 24 weeks, and then 24 to 36 it's going to be fortnightly, 14 days once. Then 36 to 40 is going to be weekly once. Okay, and then you need to know about Neagle's rule, and then Johnson's formula. Neagle's rule is you need to add 7 and subtract 3 months. 7 days and subtract 3 months, that will be your estimated date of delivery. Your Johnson's formula, you have two formulas. So your symphysiofundal height minus 11 into 155 will be your weight of the baby. This usually overestimates the weight of the baby. These are very basic questions they keep asking in your practical exams. So your first, second, and third trimesters. So history specific to that. Before that, I want to give you a general rundown of what happens during pregnancy in a in a woman. So all the processes and what actually happens, I'll be sharing now. So you have your ovum over here, and you have your sperm over here. Okay. So the sperm goes and reaches the ovum, and you have fertilization. So you have sperm, you have your ovum over here, and your sperm over here, and you have embryo formation. Okay. So embryo differentiates to then 4, 8. So this 8th stage is known as morula, and then you have 16 and 32. So as it keeps differentiating, it reaches the uterus. So a little bit about the anatomy of uterus, uterine wall in detail. So you have your endometrium, your myometrium, and your ectometrium. Okay, so ectometrium is not very important. We'll focus on myometrium, and endometrium. Endometrium is your glandular part. Okay, all the secretions are going to be from this layer. You need to know in detail about myometrium. It has 4 layers. So the 4 layers are going to be your superficial, and then your vascular layer will be over here. Then you have one thick layer where you have a figure of 8s. muscle over here, and then you have another thin layer over here. So this is the most important layer. This is known as the living ligatures of the uterus. So this is the most important thing when which prevents postpartum hemorrhage. So you have all these layers, right? So the 32 stage over here, it undergoes something known as blastocyst formation. So what happens is this embryo splits into two parts. Okay, you have your inner cell mass. So this is going to develop into the baby, and you have your trophoblast. So this trophoblast is like your hook. This hook is going to go and attach into this uterine wall. So how it's going to happen is it's going to split and form chorionic villi. Okay, chorionic villi. Now this trophoblast has two layers. So the first one is your syncytio trophoblast. Another one is your fibrous layer or cytotrophoblast or your Langhans layer. Okay, this Langhans layer fibrous is going to give support. The syncytial trophoblast is going to form the chorionic villi. Okay, so that will take place, and then so if this is the endometrium, right? So there will be implantation over here, and it will start penetrating like this, and it will open up this channel over here, and this area over here is known as your this whole thing is known as your placenta. Okay, so you see this lake over here, right? You see this area over here, right? This is where there is mixing of fetal and maternal blood. So this is the placenta. And then you have a cord formation over here. This will be your umbilical cord. So when it comes to placenta, you don't need to mug up anything. Once you understand this is where the placenta is and what it's going to be the junction between your maternal fetal thing. So all kind of exchanges, immune suppressions, bacterial transfers, everything is going to happen in this placenta layer only. So that is one important thing over there. And then your embryo starts growing, and then you have secretion of various hormones like beta HCG, your HPL, and other hormones which help in maintenance of pregnancy. So these are the basic things which you need to know, like very important orienting stuff which you might have not understood clearly. So I've talked a little bit fast over here, but I hope you guys understand what's the significance of all of this, and this is the most important thing. There are two questions which are added to this in your complication. So that is going to be your mole and your this mole thing is related to your chorionic villi and your placenta. So that would be all. Then so those are the things which you need to know about all the orientations for before going into the diseases. So I'll begin with the first, second, and trimester after taking a short break. Okay, guys. So let's continue. So I'd split into your first trimester, second trimester, and third trimester, right? So I'll give you a list of things which you can use for all of these trimesters. So in first trimester, usually you're going to do confirmation, supplementation, and education. So if any patient who's pregnant comes to you the first time for your pregnancy, you need to confirm it and book it. I forgot to mention this: booking and immunization. All right. So the various ways you confirm pregnancy, I'll tell you in the diagnosis of pregnancy. Then supplementation, like you give folic acid, and then you don't give iron yet. You give in second trimester because you have hyperemesis gravidarum, and then your nutritional supplementation, extra calories, and then extra proteins. All of these you're going to do in your first trimester, and then education, like how she should have minimal activity. She should not be only lying around, and then she should have a good social mental health, and all of those things are your education part. In your second trimester, it's going to be your monitoring of fetal growth. Okay. So when it comes to fetal growth, there are 2 to 3 important methods or procedures which you do. So one of those is your fetal kick charts. Okay. Second is your non-stress test. And then you have your Manning's biophysical profile, and then you have your modified biophysical profile. So any of these, even the second and third trimester, you can use all of these. So your fetal kick chart is other's name is Cardiff kick chart. So you need to tell the mother to count the number of kicks for 12 hours. So that'll be hard. So practically you tell them to do it for 1 hour in the morning, 1 hour in the afternoon, 1 hour in the night, and there might be chances when the fetus is sleeping, so there might be no movement. But if there's no movement for 2 days per se, then you need to go check, take an ultrasound or check the fetal heartbeat using Pinard's fetoscope. All of those you need to do. Okay. Then your non-stress test is going to be on your fetal heart rate. So when the fetus is moving, that is, you give mild stimulation to the fetus. So what will happen is there will be increase in the heart rate. So that is normal. Okay, the abnormal things are it is standard or there are decelerations. Then it's normal. You need to look at the various reasons for that. It might be due to some maternal conditions like some low-lying placenta or some intrauterine growth restriction, or the fetus is going to some kind of distress or some congenital anomaly with the fetus. All of those you can pick up with this non-stress test based on the deceleration. So you have early decelerations, late decelerations. Again, different reasons are there, the ones which I said before. Then your Manning's biophysical profile, you have 5 parameters. So you have tone, movements, fetal heart rate, amniotic fluid, and your tone, movements, fetal heart rate, amniotic fluid index, and I think it's respiratory rate. I'm not sure, but these 5, based on these 5, you assess the well-being of the child, and then your modified biophysical profile. You have only your fetal heart rate and your amniotic fluid index. So these are all the various ways in which you can test the growth of the child. Other than this, these are all like investigations. Your clinical examinations which you do, your fundal height, and then your auscultation of the fetal heart sounds, and then the adequacy of that cervix, if it's entering using that Monroker-Muller procedure. All of those things you can add in your second and third trimester. And finally, for your third trimester, it's going to be most of this is going to be repeated. And once your delivery takes place, you have your neonatal resuscitation and all of those things, and your trauma care, all emergency care like your ECGs, and then your pulse oximetry, your oxygen saturation. All of those are going to be in your third trimester. Or your intrapartum surveillance. You would use these similar methods only, like your fetal heart rate and fetal respiratory rate and all of those to assess in the third trimester. So those are all generalized points which I said. So now talking about important topics. So we have split it into pregnancy. So changes in pregnancy, diagnosis of pregnancy. So the various changes which you need to know importantly are your uterus, cervix, breast, cardiovascular system, and your metabolism and your hormones. Okay. It's very simple if you use a little bit of common sense. So what is going to happen is a baby is going to grow within the mother's uterus. So obviously there's going to be increased size and increase in number of cells. So hypertrophy, hyperplasia, all of this is going to take place. And then cervix, there's going to be increased blood flow to the cervix. So this can be elicited as various signs. So in your uterus, you have one sign called Hagar sign. This is softening of lower uterine segment, and then you have another sign known as Chadwick's or Jackheimer or Osiander. So this is bluish discoloration of the vagina, and this is pulsation seen over the vagina. In your breast, you have Montgomery tubercles and breast enlargement. So your cardiovascular system, you have increased in fluid volume and increase in RBC mass, but the proportion is not there. So it's not like both increase equally. There is relative like hypotonia or relative decreased RBC cell mass, and this is going to be your factor for anemia. So what this means is your the RBCs are going to go to the fetus, right? So some amount of RBC is going to decrease, and that is going to cause anemia in the mother. So that is your cardiovascular system, important thing. And then metabolism. So it's going to feed the fetus. So all your glucose, fats, all are increased in blood. So every process related to increase of glucose, fats in blood are going to take place. Okay. Then hormones, you have your progesterone, and then you have beta HCG. All of these will help in maintenance of the pregnancy, and then you have a human placental lactogen. So what this human placental lactogen does is it decreases the activity of insulin. So thereby there is increased glucose concentration in blood. And this is going to be a reason for gestational diabetes mellitus. Alright, so I hope this is very clear to everyone, and these are all the various changes which happen during pregnancy. So diagnosis of pregnancy is using your beta HCG. Beta HCG is one carbohydrate containing maximum carbohydrate containing molecule. It has two units, alpha HCG and beta HCG. So your alpha HCG is similar to your LH and TSH. So it is not very specific, but beta HCG is unique, so that's why we use that. The first thing is urine positive test. So when there's amenorrhea or missed periods, usually patient does this, and this is why they think they're pregnant. So this is a screening test, not a diagnostic test. And then you have a serum in your blood. So you have levels like 2000, 3000 like that. So these two are the like checking for pregnancy. Next one is your ultrasound. Ultrasound, you see the embryo, and then you do crown rump length for dating. Okay, these two important things for ultrasound. And then others, all of these are going to be your clinical examinations which you do in these things. So all these points will be repeated over and over again. So that is your diagnosis of pregnancy. Next, we are going to see the complications of pregnancy. Okay. So complications in implantation, maintenance, systemic problems, fetus related. Okay. So your implantation, if there is improper implantation, like the one I was talking about, chorionic penetration, and then your syncytial trophoblast, your cytotrophoblast, all that, right? So you have something known as moles. So it can be a complete mole or incomplete mole, and then there is one malignant condition also related to that. So what basically happens is there is too much proliferation of that chorionic villi that the baby is not able to grow, and that chorionic villi alone is growing. If it grows too much, then it is your mole. If it doesn't grow at all, then you have your abortion. Okay. So next is your maintenance of pregnancy. So I'll talk a little more about abortion. If you're not able to maintain the pregnancy due to various reasons, so possibly you just think of the uterus is not suitable, or there is some gynecological tumor over here, or the cervix is incompetent, or there's some drug use, or there's some kind of trauma. All of these are going to cause abortion. So the various types of abortion are complete, incomplete, threatened, and then impending, or abortion is definitely going to take place. That one. Then complete, incomplete, threatened, missed abortion. So these are the ones. So complete, that's total expulsion of the fetus and placenta. Incomplete, like the fetus is separated but still there in the uterus, is going to be coming out. And then threatened is abortion against closed cervix. So there is like some, usually it doesn't, like it's not aborted per se, but there's some kind of trauma which might lead to abortion of the baby. And then your impending abortion is when there is some kind of uterine pathology or some gynecological pathology where that implantation is proper and it just comes out. And then missed abortion is the patient doesn't know that she has aborted, but the fetus and the placenta have both been expelled from her body. So these are all the problems related to maintenance of the pregnancy. And then systemic problems, two of them I told you, right? Anemia and hypertension. So hypertension is related to this placenta and penetration. So when there is incomplete penetration, for example, you have a condition like this, okay? So you're going to have blood flow over here. So just imagine a thick tube like this, blood flowing through that, and a thin tube like this. So this is going to obviously increase the pressure, right? Do you get what I'm saying? Like it increases the pressure of flow, and that is why you get hypertension in pregnancy. So anemia, hypertension are your two most important things. Then related to your placenta, you have your placenta previa and abruptio placenta. So placenta previa is where the placenta is below. Below in the sense it can be at the level of cervix, or below the cervix, or outside. So there used to be like 4 grades before, but there's only 2 now. One is truly placenta previa and one is false. And due to placental migration, it might go back to its normal position also. These are few things related to placenta previa. And abruptio placenta is premature separation of the placenta. So when you have that, obviously there's going to be a stoppage of like all your nutrients to being supplied to the child, right? So it's an emergency. Clinically, both of these are going to be presenting as bleeding. So both put together are the most common cause of antepartum hemorrhage. Okay, so placenta previa is painless, whereas abruptio placenta is painful. Abruptio placenta is it's emergency where you need to go and do a emergency delivery or emergency C-section and save both the mother and the baby. Placenta previa is it can be an emergency if there is excessive blood loss and mother goes into something like a hemorrhagic shock or something like that, then it's an emergency. But if it's like in placenta previa, you should not do pervaginal examination. It's contraindicated, and you can pick this up on ultrasound. And then you have some certain complications like in abruptio placenta, you have covalescent uterus, where there is blood going to go into the myometrium and get impacted like a cyst over there. And then in placenta previa, you're going to have conditions like placenta increta, percreta, and then accreta, increta, and percreta. So accreta adhesion to the uterine wall, increta is invasion into the uterine wall, and percreta penetrates the uterine wall and reaches the other thing. Usually this occurs in case of any scar, like you have a C-section scar or something like that, placenta can go and get attached over there. So both of them are going to be seen via your ultrasound. So for placenta previa, best is your transvaginal. For abruptio placenta, it's transabdominal. Other than that, management is like you stop the bleeding. In abruptio placenta, you go and do emergency like delivery or C-section, and that is all about your antepartum hemorrhage. And then your other conditions like your fetus related, like RH positive, prolonged or premature rupture of membrane, and then your multiple pregnancy. All of these are going to add extra stress. So RH positive, you have erythroblastosis fetalis. So mother is going to develop antibodies against the fetus blood. So the fetus might be destroyed. So you give anti-D. Anti-D maintenance is the most important clinical point which you need to know over there. Prolonged and premature. So prolonged is you don't have any reasons for that. The maturity is not there, or there's no prostaglandin secretion or something like that. So for that you do induction of labor. So you can do induction of labor by artificial sweeping of membrane or amniotomy, or you can use oxytocin to induce labor. All of these are various, and then you can use mechanical methods like Foley's bulb. All of these are your methods of induction of labor. And then prolonged thing, you need to do that your Manning score and your biophysical profile and all of those to check the well-being of the fetus, because overdevelopment of the fetus can lead to passing of meconium, and you have something called meconium aspiration. The fetus can go to fetal distress. So that's what is important about your prolonged. Premature rupture of membrane and premature delivery is going to be usually related to your infections or diabetes or some complications of pregnancy. So that is the thing about premature. So you have PROM, premature rupture of membrane, and PPROM, that is preterm premature rupture of membrane. So that's the terminology for those things. And then your diseases in pregnancy, you have your CVS, and then you have diabetes. Other than that, you have infections. So these three are the most important. Others are like namesake chapters. So CVS, like I told you that there'll be change, right? There'll be increased cardiac output and stress on the heart. So you'll have some development of normal murmurs, like you have an S3 murmur in pregnancy, which is completely normal. But in an already diseased heart, like you have a valvular pathology, or you have some kind of pacemaker heart, or you have some kind of heart block or something, these patients are more prone to going into heart failure and going to cardiogenic shock. So that is why this is very important, and we need to take care of this, and this will correlate mostly with medicine. So all your signs of right heart failure, left heart failure, your echocardiography, all of those are going to be your important points for your cardiovascular system. Not going in detail to that. Diabetes, I told you about that human placental lactogen, right? That one over there. And then in infection, you have your torch infections. So toxoplasmosis, rubella, cytomegalovirus, and your herpes. Okay. Uh, all of these are very common in the genital tract, and this can be your in your prenatal period or your postnatal period also. So these infections are common and they affect both the mother and the fetus, the most important one being rubella. So you have congenital rubella syndrome where the baby develops hearing problems and eye problems like cataracts and cardiac problems like ASDs and all of those. That's an important question over there. Those are the important infections. Other than that, TB and then HIV or syphilis, your urinary tract infection, all of those are going to cause problem. What problem? Your premature rupture of membrane and like problems with the fetus. So that is all your diseases in pregnancy. And then moving on to this last bit of stages and mechanism of labor, your abnormal labor and your arrested labor. So we'll begin this with after a short break. So we'll have the next your viva. So your before going to the stages of labor and mechanism of labor, you need to know how to draw the pelvis. So this is your sacral vertebra and your lumbar vertebra, and this is your pelvic inlet, and then pubic symphysis, ilium, ischium, ilium, ischium. Okay. Then you have one thing like this. So this is like a very rough diagram. You just look at the book and you practice drawing this. But it's like this. Okay. And then you have your ischial spines over here. So your interischial spine is the most important thing when it comes to your pelvis. So how the pelvis, this is you're looking at it from the top. So that is this view, top view. You need to know also the lateral view. So this is how your pelvis is arranged. Okay. This is your abdomen. This is your pelvis, and this is your this is your pelvic inlet, pelvic brim, and pelvic outlet. Right. Like this. Okay. This is how it's been arranged. So your baby has to enter like this, squeeze through the pelvic inlet, and then come out like this. Your posterior part, this part is usually attached, and there are strong supports over here. The various supports of the uterus I didn't mention in the anatomy, so I'll mention it right now. So you have your round ligament of uterus. So why it's known as round ligament is its insertion is going to be like this. Okay, that is your round ligament, and then you have your broad ligament over here, and this is going to be attached to the pelvis bone like this. This is your transverse ligament of Mackenrod. Transverse ligament, and this is your there'll be one ligament over here, that is your uterosacral ligament. So these four are the primary attachments of the uterus, and if you're going to remove the uterus, you're going to clamp these attachments and cut them off, and then only you'll be able to remove the uterus. Okay. So you have a pelvis, pelvic inlet, pelvic brim. There are like 3 diameters over here. So you have your anteroposterior, transverse, and oblique. You can't measure your anteroposterior diameter. So you usually measure it with your oblique diameter, and you measure it from here to here. So those are all and there are different types of pelvis like gynecoid pelvis and android pelvis, anthropoid pelvis, and platypoid pelvis. So the shape of that is going to be like this. It's going to be abnormal like this. So the normal one is your gynecoid. So it's like heart shaped, and then triangular is in gynecoid is in women, android is in men, and it's usually triangular. And then you have anthropoid and platypoid, like vertically and horizontally oval. So those are the various different types of pelvises, and this is known as Caldwell-Molloy's classification of pelvis. So once you know about the pelvis, you need to know about the fetal lie, station, presenting part, and denominator. Okay, so you have fetus over here, right? Position. Okay, so if your head, this is your vertical lie, and if the fetus is like this is your transverse lie. Transverse lie is always a problem. Okay, your vertical lie, you can either have breech or podalic presentation and cephalic presentation. Okay, in cephalic presentation you can have various presenting parts. You can have face presentation, you can have vertex presentation, and then vertex presentation is the like best one. If it's there, then it will be really useful. And then you have your occiput presentation. So your all of these vertex is best, right? So face and occiput, there are going to be some small changes when it comes to your delivery of the baby. So that is your so position and your fetal lie and your presenting part is over. Station is with relation to this. So is it at the pelvic inlet, pelvic brim, or the pelvic outlet? So the most important stage is this ischial spine. This interischial distance is there, right? That is 9.5 centimeters. So that is the most dangerous or most thinnest place of the pelvis. So if the fetus crosses that area, then it's fine. Everything is fine. So denominators, you take any bony prominence in relation to the presenting part. For example, you take the cephalic presentation. Your vertex itself is a. You can take the spine as the denominator, or in case of face presentation, your malar bones can be the denominator. So like some kind of bony prominence based on which you can say that will be your denominator. So and then you split your pelvis into 4 areas: anterior, posterior, then your right and left. Okay, so most commonly they'll explain the delivery of the fetus in left occiput anterior position. So basic common things like your fetus is going to be in cephalic presentation because the biggest part of the fetus is your head. Okay, and then in front you're going to have a bladder. So usually it's going to be on your left side. Okay, on your left side you don't have any big organs, so it's usually towards your left side. So the stages of labor are going to be your dilatation, the cervix dilatation, presenting part goes in engagement, and then engagement till full cervical dilatation. Then dilatation, full cervical dilatation is 10 centimeters, and then full from dilatation to delivery of baby, from delivery of baby to delivery of placenta, and finally 2 hours after placenta delivery. Alright, these are your stages of labor. Then mechanism of labor. simple mnemonic, head fire. So engagement, descent, flexion, universal flexion, internal rotation, and then extension, restitution, and external rotation. So that you can't, like, I can't explain it. You need to see it, or they would have explained it with a dummy model in your college. So I can't explain the mechanism of labor, but basically it's a very narrow space, right? So the baby like fits through the pelvic brim via these maneuvers, and it most of all of this is going to take place because of the action of levator ani. This is a fan-shaped muscle which surrounds the uterus. So when it contracts, one part will contract, other part will relax. So based on that, there will be movement of the fetus. Those are all the things when you need to know about the mechanism of labor. So these are all the normal things. So abnormal labor, there are too many details in this. I'll just tell you about breech and transverse lie. So breech is where you have podalic presentation. Now breech is common in like multiple pregnancy, and then if there's some kind of growth restriction or some kind of polyhydramnios, all of those conditions are going to cause abnormal presentations and labors. So what happens in breech is you have three types of breech. So you have complete breech, and then extended breech, and foot limb position. So complete breech is where your baby is in full flexion. Okay, this is now you can go for normal delivery for this. In this, there is extension of the knees. In this, you have extension of both hips and knees. Okay, this one also you can go for normal delivery, but you have some maneuvers like love set maneuver and one more maneuver. So you will insert your hand and you will flex the elbows. So I'm not able to recollect that maneuver's name. So one is love set maneuver, and one more maneuver there. These two are done in pre-breech presentation, and then you can do external version or internal version. So all of these you need to like monitor the baby, like you rotate the baby from one position to another position. This you do more commonly in your transverse lie than in your breech presentation, but these two are some things which you need to focus on. And then your mechanism of labor is going to be slightly different for breech. Just remember one point, that only in vertex presentation the baby is going to come out with your with the flexed head, with the extended head. Every other condition, the baby is going to deliver with the extended head only. There are two methods also for delivery of this breech. So one is your Marshall-Burns technique, and you have your forceps delivery, and there is one more technique, like forgot its name. These are all Marshall-Burns technique is where you do 360 flip with the baby once it's been delivered, and you put it on the mother's stomach. So those are all the practical points per se, but this is the thing about breech and transverse lie. So for transverse lie, this version, like internal version, external version, and in this there are more chances for arrested labor. Like for example, when there is one shoulder presentation or one hand alone of the baby comes out through the goes into labor and it gets stuck over there, then there might be pressure building up and it's a complication. Like with proper gynecology obstetric care, this is not going to happen. But if something like that happens, you need to know how to manage it, right? So that's how it's given in our textbook. Only question they're going to ask is arrested labor. Maybe they might ask you in your viva. So the last thing I'll touch upon is your C-section. So cesarean section, you have your classical and your newer one. So for most of gynecology and obstetrics, just remember this incision, okay? Fanelstein lower abdominal incision. So this is your abdomen. You have umbilicus over here, pubic symphysis over here. Here is where you put your Fanelstein incision. This is the newer incision, and you can do transverse incision also. No, you can do a classical vertical incision. This in case of cervical malignancy. You have some kind of problem in this area, then you can go for a classical incision. Classical incision, there's going to be a problem with healing scars, and then I told you that placenta, creta, increta, percreta, and then while next delivery there might be rupture uterus. All of these are problems related to your classical incision. And then when it comes to your uterine incision, right? So what you do is known as Munroker Muller incision. Okay, that is the name of the incision. I'm not sure how you. I'm not sure. I don't want to give wrong information here. So Munroker Muller incision, and then these three supports are there, right? The supports of the uterus, your transverse ligament of Mack-and-Rod, your broad ligament, your round ligament of uterus, uterosacral ligaments. All these are clamped. The blood supply is cut, and then you. Yeah, that is for hysterectomy. For C-section, you do this. You open to the baby, you reach the baby, you remove the baby, and you remove the placenta. And then, if you're going to do some kind of contraceptive procedure like hysterectomy, then I told you that those three ligaments you clamp them and you cut them, and then you stitch it back together. So that will be all. So other than this, there are one important topic which is programs related to maternal health. I will send a presentation PPT file for that. So with that, I'll end this session. I hope you guys found it really useful. So thank you guys.